I'll start with something, Rob, you touched on at the end, which is this issue of the fact that many people who appear to have phenotypic FH don't have a documented single gene mutation. And many, but not all, have polygenic hypercholesterolemia. So at the end of the day, do people who look like they have FH clinically but don't have a specific gene mutation, should we be calling people like that FH? Should FH be the diagnosis? I'd love to hear your thoughts, and then maybe Ruth, you can chime in.
Yeah, so I think for simplicity, Dan, maybe, but then so then I've heard people say, polygenic FH, or it's definitely it's hypercholesterolemia, and yeah, so polygenic hypercholesterolemia. I mean, we would need to rethink the nomenclature. I think so. Amit Kara and I had an editorial in Circulation a couple of months ago where so I think as a result, I mean, the genetic information is forcing us to, as it is for many conditions, many classical genetic disorders, it's forcing us to reconsider it. So that might be the shortest answer.
Ruth?
Rob, I expect you don't know this, but it's a slightly lower risk, albeit very high, in patients with polygenic hypercholesterolemia. Is that because the age of onset is later? Obviously, in FH, we think of you can diagnose this in cord blood, but I wonder if there are any data at all on the age trajectory of cholesterol in those individuals.
Yeah, so that's being looked at. So I think that the short answer is, you can still see the polygenic effects in childhood, like where that's been looked at in children's studies, but they're much more nuanced. So it seems like they do become more amplified with age. So there's probably you're probably right about the age effect. The other thing is that then when you break them down, even in the clinic, they're the polygenic ones, the ones they always have they're like a millimole per liter less with LDL compared to the overall group that have a monogenic mutation. If you just take all comers with a monogenic mutation and then all comers that however you define polygenic, the phenotype is always slightly milder with polygenic, at least biochemically, but they respond as well. So we've looked at it. They seem to respond just as well to statins in terms of percent reduction. They respond just as well to PCSK9 inhibitors. There's the monogenic is starting from a higher level, but on a percentage basis, it's exactly the same. So it still ends up being, empirical treatment. I mean, you're still treating to a target LDL and you're still titrating the patients. So we're not quite at the point yet where you can predict therapy based on monogenic versus polygenic.
So related to that,
and the other question,
go ahead, Ruth, please.
Yeah. One last polygenic. So if you run a gene chip, of course, you can do a polygenic risk score for everything. Right. And a polygenic risk score for coronary disease, of course, takes into account millions of genetic variants that don't affect, lipids or any other traits. Is there a role for that? Because obviously we can predict cardiovascular risk beyond what we know about conventional risk factors. And that may be particularly important in patients who have FH or simply have severe hypercholesterolemia.
Yeah, 100%. So, and I know, Dan is interested in this. A lot of people are looking at this again. So like, Sake and Amit Kara, like many people are looking at it. But so within FH, even if you then, so the coronary, I think, the large scale coronary risk polygenic scores would be hugely, it would be, and there are some data to show that that's actually the case. But even like, things like LPA, smoking, so traditional risk factors, so those are also super important for FH. And if you have like 2 or 3 traditional risk factors, like diabetes, on top of having FH, well, then already your risk is higher. So we need to be, without having to do a DNA testing. But but I think then if people can ever agree on a consensus of what one of these big omnigenic scores should look like, and then create, standards around the world for how they should be measured. And so there's like, that certainly should be part of the assessment of patients in the future.